The mother has registered and booked a case at a local PMC hospital near Ghatkopar. She has taken IFA tablets. She has taken 2 doses of injection daily. And the weight gain during pregnancy has been inadequate. It has been around 8 kilos. So there have been four ANC scans done, and all of them were told to be normal. No history of blood transfusions or no history of any hospitalizations during ANC. And there has been no history of any pregnancy-induced hypertension, gestational diabetes, no history of fever with rash or any history of chronic illnesses. Our history, this was a full term. This child was delivered at full term, delivered by LSCS in view of previous LSCS. The baby cried immediately after birth, and the child had low birth rate of birth around 2 years. There has been no history of NICU stay, and the child has been discharged on day of life 5. There has been no history of neonatal jaundice, and the breastfeeding was initiated 3 hours after the delivery. Developmentally, child is 1 year, 6 months old now, and he can walk alone and he can run. Fine motor, he can scribble and make tower of 2 blocks. He knows up to 6 to 10 words at his age, and he can read Bible. There is stranger anxiety that he has developed, and on hearing assessment, the child responds to commands, usually turns his head to the auditory stimulus, and also visually the child fixes and follows, maintains an eye contact when spoken to. So the child has achieved these appropriate knowledge. Going ahead with the Going ahead with the immunization history, the child has been immunized till date as per the national immunization schedule and to the dietary history. So, from birth to 2 months of age, the child was exclusively breastfed by mother and on demand around 7 to 8 times a day. And each breastfeed used to last for around 15 to 20 minutes. And night feeds around 2 to 3 times night feeds were given regularly by the mother. From third to fourth month of life, the mother actually switched to powdered milk because of lactational failure. There was poor milk output as per the mother. Mother was complaining that the baby stays hungry even after feeding. So that's why she switched completely to powdered milk. So this powdered milk was given in inappropriate dilution, half scoop of powder with almost 50 ml of warm water. Initially, she started feeding by one teaspoon feeding, but because the child wasn't taking it and it was poor acceptance by the child, she switched to bottle feeding. The frequency of bottle feeding was around 8 to 10 times. From 4 to 6 months onwards, because of affordability issues, the mother switched to diluted cow's milk. So the dilution was half glass of cow's milk and half glass of water. And this was given by bottle and on demand feeds usually around 10 to 12 times a day. So then complementary feeding was started from seventh month onwards. So complementary feeds were introduced, starting with biscuits. Usually Parle biscuits were given and khichdi. And the child had poor acceptance. The child used to spit the food out as per the mother. So the child is still predominantly on a milk-based diet. So his diet consists only of four food groups, and the calorie deficit they expected is at this age, calories per day is 1060 kilocalories, where the child is only taking 650 kilocalories. So the deficit is around 410 kilocalories per day. The protein intake that is expected at this age is 16.7 grams per day, where the child's intake is around 14 grams per day, and the deficit is 2.7 grams.
Share this PPT on Zoom from his phone.
It's okay, go ahead.
You continue.
Moving on to the family history, the child has an elder sibling who's 2.5 years of age. So the birth spacing is only 1 year between two siblings. And there has been no history that is suggestive of any chronic illnesses or no similar suggestive of any chronic illnesses. The On probing, the mother gives history that the elder sibling also has similar dietary habits, and she also has similar complaints of somewhat. On socioeconomic history, the mother is 20 years old and father is 23 years old. Father is a daily wage worker. He's studying till ninth standard, and he earns around monthly 10,000 rupees a day. And they have two children. The elder sibling is a sister, 2.5 years old, and our patient is 1.5-year-old male child. So according to they live in a one-room paka house with a separate pipe water supply and a common public toilet, and a pipe drainage system in their locality. So this family belongs to class 4 according to modified socioeconomic status scale.
Don't go to the summary. Go back to the first.
The PPT waves. I'll share it.
Very well presented history and very well narrated. Few points, obviously, we can keep adding on what you have already presented. But this is very good. So, what do you mean by inadequate weight gain from last 6 months? How did you, mother said this complaint, how did you verify this complaint? How do you verify whether there has been inadequate? See, after mothers who come to the consultation, they say, my child is not doing adequate. How do you judge whether this is adequate or not? Obviously, you don't have a growth chart. If you have a growth chart, it's objective. On history, how do you judge?
Inadequate. As he said, there's inadequate weight gain as compared to his peer.
But in your history, you said the elder one is 2.5 years and was on similar dietary program, correct?
Yes, sir.
So then the growth pattern should be more or less the same. You're right. So that is one way of judging. Any other way of judging? You could ask whether they have, yes, very good. So whether they have noticed any clothes are wearing the same clothes, the child is not growing in height, the amount of urine the child is passing, the consumption of food or milk has gone down or has remained same over last 6 months. Okay. Now, on your history, it also says that the child was all right till 6 months of age, and the child has not been feeding well. So, one pointer in your history, which you have presented so nicely, is that we are all tuned to follow a particular schedule or particular pattern of presentation, which is appropriate. So, if you see your presentation here, chief complaints followed by HOPI, followed by relevant etiological factors that you have narrated. Then when you go to left-sided history, in this child, it may be important to push your dietary history first up and then say the less relevant histories. So what is more relevant here? Even the birth history is relevant, immunization is relevant, growth is relevant, everything is relevant. But for your this particular condition, once you say that you are not dealing with any failure to thrive issues, then you are going to talk about dietary history. So what is the difference between failure to thrive and not putting on weight? When will you call it failure to thrive and when will you call it malnutrition?
Failure to thrive is when on the growth chart or when matched against the peers, the child feels like he's below -2 standard deviation for the weight and height. Then we call it failure to thrive. Whereas not putting on weight, probably he's going down the hill and eventually will be failure to thrive unless intervened. For separate occasions, failure to thrive will have growth faltering. It will cross two center lines.
I'll rephrase my question. We understand that failure to thrive and malnutrition are similar, but malnutrition is one of the causes of failure to thrive, right? So if nutrition is not the reason for not thriving well, you would use the word failure to. And typically, we use the word malnutrition till 5 years of age. Beyond 5 years of age, if there is no weight gain, no height gain, then we try to call it failure to thrive. Primarily because nutrition may not be the only reason for somebody not growing beyond 5 years. More likely to have other constitutional symptoms. So you can have sometimes, most of the time it will be failure to thrive. If you have, for example, cardiovascular problem, if somebody has malnutrition, you understand? So, or metabolic state like malignancy or something like that, the child is not, or endocrine cause, and the child is not putting on. So, There's one more contradiction in the sense that there is no history of recurrent loose stools, and then you're going to go back and say that the child had loose stool on probing. So you can start straight away say here itself, rather than having to contradict yourself. So finish your story here and then highlight that this may not be enough to explain. That's what I'm saying. There has been a history of loose motions, but not bad enough to cause this kind of failure. So what history, what other history you would have wanted here from loose stool point of view? Can you go to the next one? So let's focus on this past history. Because if you go to the no history, there are going to be few more conditions which you will obviously be able to put. But as Amdekar sir says, those complaints would come from the parent anyway. Okay, so if you say somebody had recurrent seizures and not putting on weight, or not developing and not putting on weight, etc., then those things would come from the parent anyway. So even if you have not mentioned one, we are all right with that. Let's look at past history of. So what can somebody elaborate on this? Do you want to ask any more questions? Because apart from nutrition, that's the only positive history you have.
Are the loose stools recurrent? Oh, this is the only episode. So the loose stool, the duration of the loose stool and doesn't seem very worrisome.
Any other questions in this history? Worm infestation. What do you want to know in worm infestation? Can you give us some more details if you have asked? Otherwise, it's fine.
Since when it started?
So, maybe. When they have noticed first.
So they noticed it around a month back,
And they have given one
they have
dose
given
of
some,
medication.
they have taken some local treatment, and then it has resolved.
So, generally speaking, this is good enough. But the point is, you write pica on the top and then you write worms. Is there an association between the two? What?
Tendency to eat geophagia, tendency to eat soil can cause worm infestation.
Very good.
Iron deficiency anemia is much common. Because pica also, and because of pica can have burden.
Very smart. Actually, this was a trick question because normally you will end up saying that worms will lead to anemia, right? That's the other problem to many people will think. But we have to remember that most likely it's going to be either pinworms or pinworm or roundworms. Hookworms very rare. At least when mothers come and complain, most commonly you're going to see pinworm and roundworm. Not classically associated with anemia, but as you said, the association can be the other way. Because of pica, there can be higher incidence of worms. But what I am interested in is if these loose stools were frequent, which is likely because of the feeding habits that we have described, versus if these loose motions were responsible for not putting on weight. So, what other history you would have if there was a GI cause, apart from the fact that you have mentioned about malabsorption and foamy stool?
Probably cow's milk protein allergy. Whenever the child is fed cow's milk when she started around 4 to 6 months of age, since that time, child has been having recurrent loose stools post feeding, and since then he may not gain weight.
Very
Blood and stool.
blood in the skin. Yes, that's what I was getting. So one is, of course, as you rightly said, cow milk protein allergy, but extremely rare. But we must not forget that inflammatory bowel diseases are also can be present in very young age group, and there is a separate entity now for inflammatory bowel disease in the loop or in the infantile stage. And there you will have loose motions, but they will be not necessarily watery and this, but they will have blood and mucus, multiple multiple episodes occurring along with altering of the growth.
So in the ANC period only itself, the mother had poor weight gain, early onset pregnancy. So can that be a factor in not gaining weight other than the nutrition?
That's a good question. So the point here is, what are we looking at? Are we looking at a early SG or a late SG? Right? I mean, whether it's a syndromic baby or some other issues in the first, second trimester, and the baby is small for gestation, or because of lack of nutrition in the mother, age is small, probably second child already, very small gap between the two pregnancies. And so her nutritional status is not enough. And then you would have somebody who is like a late SGA. Now, if there is adequate nutrition given, one would expect the weight gain to be there and there has to be a catch up growth. And that would be complete by 2 years. He's already 1.5. So no faltering of growth in last 6 months can be attributed only to low birth weight baby who is otherwise healthy and well fed. That's how I would look at it. Plus the milestones have been normal, mental milestones have been normal. So generally not thinking on those. Oh, good. Yeah. Can somebody discuss each para and tell me what do you understand by it? Where do you think, when do you think the faltering started? Is the feeding okay in first 2 months? How do you know? Urination frequency is okay. Mother is not having enough milk. 2 months only she has switched. So obviously it won't happen one fine day. It must be that the milk is less from the beginning. How would you know?
The number of times the urine is passed.
Yeah, exactly, right? So that's an important point to mention. At least when the baby is exclusively on breastfeed, it's important to know how many times the baby has passed urine. What else? What else do you want?
Weight gain in first 2 months.
Excellent. So we all have to maintain growth charts, but obviously this patient would have not come to you with the growth charts. What else can we ask? You asked how the child was in between the feeds. Was the child hungry? Was the child irritable, crying, asking even after being fed, the baby wanted more and things like that. Some more details on that. Okay? So that will tell you whether there was a problem in the second, from birth to second. Now tell me one thing, from read the second para and the third para, third to fourth month and fourth to sixth month. Read it once carefully and then I'll ask you the question. So it says powdered milk in inappropriate dilution, half scoop powder in 50 ml of warm water. Okay. Method of feeding we'll discuss later. Switch to cow's milk, half glass cow milk, half glass water. Okay. Given a choice, which will deliver more? Both are bad, we know that. Not good at least. The warmer one? No. What is the standard dilution? Let's think like that's the easiest way. One scoop in 30 ml, right? We are not talking about some of the other specialized formula where you have 1 in 60 ml also. We are talking about the standard milk formula. So it's 1 in 30. Now you put half in 50, you are diluting how many times? Almost 4 times, or at least 3.5 times. You agree with me?
वाटर का डबल किया फॉर्मूला का हाफ किया
Here half glass milk, half glass water. So it's only 1:1 then. So though it looks bad, actually the child is getting better than what you're getting from the formula. And can somebody tell me the reason why that must have happened? We are assuming that all this information is accurate. He has tried his best and mother must have also given good thought and given him these values. Can you tell me what could be the reason? Fine. Funds, right? Financial. Very good. So even that half scoop of milk powder will cost more than the cow milk available to her. We're assuming that they're getting standard quality cow. We're not thinking of pre-dilution occurring before that milk comes to the house. That's another added problem. Now, another interesting thing to notice here is that you have a child who has been bottle fed from Vati spoon to bottle fed, and itself means that probably the child was not taking adequately with Vati spoon. And if the child is hungry, baby would take with Vati spoon food, and there is no reason for them to. There is no reason for them to switch to bottle. The other thing is, you see, they're usually fed around 10 to 12 times. A 4 to 6 month old child does not have to be fed 10 to 12 times. What do you think is going to be the urine count here in the first, second, and third para? Normal, more or less? Normal being 6, at least breastfed child, minimum or average, minimum being 6, average being 8 to 10. And it can be more for normal exclusive breastfeed. But talking about if you want to find out adequacy of feed, what will be the urine count in the first? Assume, can explain.
Around 6 to 7 times.
Or maybe less, right? Because we are saying that the child was not fed adequately for 6 hours. Second and third, more urine, correct? So urine count is a good parameter provided the dilution is accurate or appropriate. If the dilution is more, then obviously the urine count will be more, but the amount of calories going in will be less. Okay. It's Parle. How much calories? How many calories in Parle?
30 kilocalories.
30 kilograms. Which biscuit has lower calories than Parle?
Mari biscuit.
Mari biscuit.
Yeah.
20 calories. 22 calories. No, don't smile. Because most of your PMs will not be eating Oreos and bourbons. they will be eating Mari and Parle-G at the most. Once in a while. When they have a good day, they will have. Other than that. So it's good to know common food things like banana, glass of milk, party of rice, party. That basic. Okay. You said consists of 4 food groups. Can you elaborate?
The child is taking cereals as food groups. Then
No, what in cereal? Sorry.
so actually, a half a part of roti or some part of roti, that's it. With the khichdi, sometimes mashed with it. Then along with that, khichdi will have rice. The child also has predominantly dairy. Uh, and khichdi, sometimes she said, sometimes she adds carrots, parts of carrots. So vegetables is another one.
Interpret your calorie and protein. Do you think that looks normal or any comments on that?
Because the child is predominantly still on cow's milk, 100 ml of around cow's milk will have 3.3 grams of protein. So he's taking a lot of still predominantly milk fed. So it is, even though it is nearby sufficing the protein requirement, it is not sufficing the calorie requirement. So it is much more calorie depleted than protein depleted.
So what would you see typically in a child who is calorie depleted and
A man's was
or in demand? You don't like it. So this is fine. So when we talk about this, so now how are we going to approach this child who has not been? First of all, though the mother has given, really article, I'm not very sure.
In between.
Even if the mother says 6 months, they have not noticed the growth. When do you think is the onset of calorie deficit?
I think it is as soon as she switched to the cow's milk, which is diluted, and then the complementary feeds.
Or even before that?
Even before
Because when they were
probably.
giving formula also, it was diluted. Any other? So when you approach this, first thing you want to know is, is there anything else which is responsible for malnutrition? So that you have ruled out, more or less. may at least know on history there are no contributions. The second thing you want to know about is when is the onset, because that will tell you what to expect on anthropometry. There's going to be only weight faltering, height also, length also faltering, or whether there is a head circumference affection also, which what you asked. So if the problem started very early in the intranatal period, antenatal period, then you would think about even the head circumference. Or if the faltering is very severe, in that case also you might have head circumference. Then next you want to decide whether this is going to be, what is the severity of this malnutrition. Okay. Fine.
So my impression on the basis of history is 1 year, 6 month old, the 1 year, 6 month old child immunized till late and developmentally normal is most likely a case of acute and chronic malnutrition precipitated by a recent episode of diarrhea without immediate complications and with the probable etiology of either faulty feeding practices, that is my first differential, and second is underlying chronic illnesses that might come up on examination or investigations.
Would you admit this patient on just on this, or would you go for a home care? Assuming that he's not dehydrated, etc. It's not for the loose motion part. Even without the examination.
Exactly.
So why do you admit? And is an esteemed institution. What you're doing has to have a reason.
So we admit them to first of all evaluate the cause of malnutrition.
Why do you evaluate the cause? Okay.
Evaluate rehabilitate.
Can you evaluate, not evaluate on OPD basis?
The kind of patient base that we have, they are more likely to lose to get lost to follow.
Yeah, it's not about you, it's about everybody. Not if they had all the resources possible, then they would not develop SAM. They develop SAM as an issue. So what you are saying is correct. So here the reason would be one to find out the etiology, and second because you are not sure about the conducive home environment to provide them with. Even if you supply with food, it may not be possible because mother may have to be taught and child's appetite has to be checked. What is an absolute indication for hospitalization? When would you admit?
Any danger signs?
Any danger signs? Okay. What else?
Single parent.
Age. Age. Now I know you will say Sam is only 6 months and above, but below 6 months also you can have. So anybody who is below 6 months automatically gets to be needs to be admitted. And as you said, danger signs or any complicated SAM would require hospitalization. Present. Any other questions on this?
Can you rule out HIV on history?
Can you rule out HIV on history? Somebody wants to answer that before I answer. So this is the second child, both parents alive and well, antenatally managed well, unlikely to be HIV. Also, if it's an HIV infection in the child causing malnutrition, there has to be other what do you call it? Other complications occurring of HIV. So if it's only HIV positive, but no other evidence of any other infection or any other problems.
Moving on to the examination part. In the general examination, the child is euthymic, the child is alert, the child is lying comfortably supine and seems interested in his surroundings. His heart rate is 114 per minute and it's regular normal volume pulses and which are bilateral. They are mixed case patients. Sorry. The respiratory rate is 30 per minute, which are regular respiration. Saturation is 98% of movement. Extremities are warm, pulses both peripheral and central are well filled. The capillary refill time is less than 3 seconds, and the BPD is 78 by 40. For this child, around 50th centile, which is taken in the right in the supine position. Parallel is obvious on general examination, as well as there's no history of icterus, cyanosis. There has been no history of any bilateral pediatric edema and flooding. On head to toe examination, there have been palpable bilateral cervical lymph nodes, which are substantial. Moving on to the anthropometry part. So this child's recorded weight is 6.5 kilos, which is as per the WHO growth charts is less than -3 standard deviation, falling into the severe underweight criteria. The length is 76 centimeters, which is between the -2 and the -3 standard deviation, which is called, which satisfies the criteria of stunting. The weight for length at this age and weight length is less than -3 standard deviation. And the mid upper arm circumference is around 12.7 centimeters, which is at -2 standard deviations. The head circumference is 46 centimeters, which is within normal limits for this child. So the impression on anthropometry is acute on chronic malnutrition because there has been severe weight, the child is severe underweight as compared to the height. So there has been a component of chronic malnutrition which is ongoing, but the weight is much more affected. So probably an acute on chronic malnutrition, which is shown by stunting and the severe underweight of the child. So on head-to-toe examination, the anterior fontanelle is open. It is at level and it is around 3 by 3 centimeters. So here they are sparse and easily pluggable. There is frontal bossing. Eyes are normal, ears are normal. There have been no signs of vitamin A deficiency in his eyes. There has been poor oral hygiene, which is by the caries are obvious and the gingivitis is also obvious on oral cavity examination. On neck examination, there are bilateral subsentimental non-dental cervical lymph nodes which are palpable on at level 2 and level 3. Wrist widening and knuckle hyperpigmentation is also present. On skin, there have been patches of rough skin, mainly on the exposed areas, sun-exposed areas, on the extensor surface of bilateral upper limbs. The chest of this child is normal. The spine is also normal. The perineal region, there are no excoriations present. And genitalia, there are normal main genitalia, bilateral testes, frontal. Systemic examination. On inspection, it appears it was soft and a flat abdomen with no scars, sinuses, or dilated veins. There, on palpation, the inspectory findings are confirmed. The abdomen is soft and non-tender. Liver is soft, palpable around 1 centimeter below the right subcostal margin, and spleen is not palpable, and bilateral kidneys are not palatable. There has been tympanic note heard all over the abdomen on percussion, and vowel sounds are heard normally on auscultation. The rest of the systems reveal no signals. All of them are within normal limits.
So how do you explain the length? What do you feel? Interpret the length. What is -2 to -3? Mild, moderate, severe? Moderate. And less than minus? Less than -2? Less than
Mind.
mild or normal? No. There's nothing like mild. The idea to emphasize it, it's only moderate and severe mild, moderate and severe stuff. So anything which is within -2 is normal. Here, what I want to emphasize is this child was born 2 kilos and is now 76 centimeters. So forget the weight and wait for length for a moment. This could be near normal growth of that child. Because as we are discussing at 2 kg, he may not be 50 centimeters to start, maybe lower than that. And so, though it appears -2 to -3 SD, it would still be within normal. But I agree with you. With weight for length more affected and weight very severely affected, we will still call it acute on chronic because your length is showing -2 to -3 SD. Also, on history, you have a history which suggests acute on chronic. Okay, if you had some event which caused the weight loss recently, then you would try and argue that this length could be a normal length because the child was small for birth, small for age at birth. And so the length may still be normal. You get my point? So this interpretation is otherwise correct. Head circumference 46 centimeters. What are your comments? Yes, sir, normal.
Latest.
Reservation of brain.
Some asymmetric type of myogenic AVM
Right.
during angina. Because of mind open.
Yeah, so one is definitely that the child did not start with a small birth, small head size. And also, as we know in malnutrition, there is preservation of brain growth and that gets affected at the end or last. So that proves one more time that 46. Could this be hydrocephalus? That's why it's 46. Otherwise, he has PEF, he has frontal bossing. His AF at 1.5 years is 3 by 3 centimeters. That's quite a bit. So this is hydrocephalus.
Then the presenting complaint will be in gradual increase in head size.
The AF is open. The gradual increase in head size, who notices? This is normal size head for the baby. You have only said it is normal. So if it would have come to you and me, we would have said normal head size. There is a question of thinking about it. Correct. So other sides of hydrocephalus are not there. On history, nothing to suggest. So now the next question. How do you explain 3 by 3 centimeter with frontal bossing and wrist widening? Rickets? Child is not growing. Rickets is a disease of growing bones. And that means growing child.
Calcium. Calcium and phosphorus.
Why poor calcium and phosphorus intake? That is only on milk. Best source of calcium and milk and phosphorus. Isn't it? That is predominantly on milk. What is the difference in calcium phosphorus in breast milk and in cow milk? The ratio is different. If the ratio is different, the absorption will be poor. That is not the reason for this. If there is a severe vitamin D deficiency, then one could get changes of rickets even in a child who is not. Knuckle pigmentation, B12 deficiency. Any other signs of B12 deficiency? For this child, you would ask.
Reddish tongue.
BP term. Okay. How many of you have seen BP term? No. You see hyperpigmented tongues. But I agree. That's one. What else? Correct. Tremors. And in small babies, you have irritability. ITS. So there are no obvious signs of skin and hair changes. Easily pluckable hair is fair. Could be a sign of malnutrition. It may not be a sign. You have a flag sign on hair. What does that represent? When you get on and off nutrition. If somebody has had no nutrition forever, then you're unlikely to see that. Similarly, if there has been a period of growth and then no growth again for whatever reason, then you can still explain the mild rickety changes on those places. But here, more likely because of no vitamin.
So, how do you check for easy pluckability? Do you go and pluck the hair?
Don't do anything that causes pain to the child for our sake. Anyway, give them. Liver soft, palpable 1 centimeter below right subcostal margin. What is your interpretation? Normal, abnormal? Normal. If it was 3 centimeter, normal, abnormal. Can have fatty liver.
Depends on the span.
Depends on the span, right? Because of hypotonia, there could be visceroptosis. And so in children with SAM, one can get liver and spleen palpable. Important being soft liver, soft spleen, span being normal, and no suggestion any other condition possible.
So my diagnosis for this child is a 1 year, 6 month old male child, completely immunized and developmentally normal child is a case of severe acute malnutrition, precipitated by a recent episode of diarrhea without any immediate complications and radiologically quality feeding practices.
So what investigation should somebody can have? We accept this diagnosis. So what is the next thing that you're going to do? This patient has just come to your hospital. You said admit.
Check the blood sugar first.
Check the blood sugar. What it should be above how much? 60, 54, 45. MCQ. The word of I think it's 54, but I could be wrong. Check. But if it is low, what will you do? Say it loudly, because this mic's not doing good. What is symptom?
Seizures, like they not are able to take the orally.
Correct. So, if there are CNS signs of hypoglycemia, obviously we will go ahead and give IV. Otherwise, you will try to give oral. If not taking oral and no neurological complications, then you will give NG2. What else? After sugar,
Electrolytes.
temperature. Which is obviously taken. You may not have steroid. What else? Electrolyte. Okay.
Complete blood.
Complete. What do you expect on it? Hypernatremia and hypokalemia. Could be low. Why? Calcium will be low, ionic calcium will be low, or both will be low. What is ionic calcium?
Something that is more active.
Correct. So that's the more important one for your hypocalcemic change. Any other electrolytes that you are concerned? You may not check it in every patient. Magnesium. What else? Complete blood count. Why do you want to see the
Want to see the hemoglobin, you want to see the WBC count. Look for if there is any shifting from this register of sepsis.
So if the WBC count, if the CBC is normal, what antibiotic would you do? A horrible statement. The CBC is normal. Which antibiotic will you give? Complete senses, I'm asking. Amoxicillin. Why? You're right. So SAM patients, WHO policy is to give, if they are admitted, then ampicillin gentamicin. They're not admitted, you may not even give it. Most of them you would say admitted ampicillin gentamicin. Send a blood culture, do the sepsis screen, make sure they are not infected, but give that to start. What else? Sorry? Stool routine. Okay. Right. How will you know the child is under dehydrated? So what I'm doing now is I'm going to ask you common questions which are asked for a patient of SAM. Because otherwise discuss SAM is. We will cover investigation management. So let's answer fast so we can cover a few more. How will you check dehydration? Assess dehydration.
We look for things, signs of tachycardia, we look for perfusion, we look for hemoglobin time. If the AF is open, we look for the AF, we look for the eyeballs. Skin pitch is not that reliable.
Even eyeballs are not allowed because they SAMs usually will have them. But most importantly, heart rate. And we say blood pressure, but blood pressure is really on the at the end and not early. When we give IV fluid to a child with SAM, indications for IV fluids. Shock. Shock. Just one word is shock. Okay. Otherwise, it's either oral or NG. So, if you have hypernatremia, can you give diuretics? So this will, why you don't?
Electrolyte imbalance.
Correct. Further called electrolyte imbalance plus dehydration. Very difficult to detect and cure. You started IV fluid. How do you know it's overhydration?
Basal crepes and
Basal crepes, you are in ICU state. Before that. You want to prevent basal crepes.
tachycardia.
Tachycardia. Very good. So what tachycardia? So heart rate increased by 15 per minute, respiratory rate increased by 5 per minute, and of course puffiness which were not there and has come up. Edema may be there already, or if it is not there and then it comes up, then you say it's likely to be overhead. How do you start feeding this cell? Oh no, sorry. So other things we have to talk about is what? What other things you give? Vitamins, iron, minerals, trace elements. Iron, no. Iron. You said iron deficiency, no? Pica.
May cause free radical injury at this time.
So apart from it may cause constipation or loose motion, but more importantly, free radical injury, and that's why you wait for the child to start eating. And typically after 2 weeks of starting the treatment, successful treatment is that. How do you start feeding? So we are talking about a patient who is admitted, not on IV. What is appetite test? That's one of the ways to decide whether the child has to be admitted or not. Depending upon weight of the child, there are
Ready to use therapeutic food.
ready to use.
They're not quite very. We give them a time limit, usually in half an hour, and then a set amount that is supposed to be finished.
So if they can finish it, then appetite test is pass or clear, and so then this patient can be managed at home or under supervision. But otherwise, comes one more indication for getting hospital. How do you start feeding the child? How do you start? First, encourage orally. This kid is how many kilos? 6.7.
They started for these children.
What is the starter?
They are 75.
What is it?
75 kilos.
75 kilos. Very good. Let's give easy answer first so that you have time to think for the remaining. Yeah.
Milk powder, corn starch.
It's okay. I don't remember it. Let's say read up it. But you should know what it starts with F7. Principle should always be known. Details can be checked. So F75 typically has, how I remember at least, is it has 1 ounce of milk. Okay. Then it has 1.5 of sugar, half of oil, half spoon of oil, and make it 200. And that comes to 70, F70. That's what roughly is what I remember. Similarly, you say which ORS to be used for this. Resuma. You have Resuma as an option. You make Resuma. So IFT recommendation currently is to use low osmolarity WHO. It is as good as using a Resuma. Okay, so it's fine to use that, but you should know what Resuma. What is the low, how much electrolytes and glucose are there in low osmolar? Meaning, I should not even use the word low osmolarity. Now, for WHO ORS is only low. 75, 20, 75. 75 is the magic figure, so that you remember that it's easy for you. 75 of electrolytes, 20 of sodium. 75 of sodium, 20 of potassium, and 75 of glucose. So that's your WHO. How do you know that the child is growing or accepting? How do you increase? So normally you start with 100 ml per kg and go on to 130 ml per kg. And then keep on increasing every 10 ml till the child leaves behind some. That's the standard pattern. When do you consider discharging this patient? When do you consider discharging?
The complications that have been treated.
Very good.
The child has shown adequate weight gain on 3 subsequent days. So 5 grams per day for 3 consecutive days. For 3 consecutive days. Then the mother is confident enough to take care of the child. The mother knows how to prepare the food at home. The mother is able to interact playfully with the child.
It has been explained about the warning signs and when to come back and report. Then there are questions about when you can do early discharge, and there are quite a few other things. Any other questions or we move on? Well,
I tell me what
Seven-year-old male child who has taken their birth order, born out of a non-consanguineous marriage. A resident of Mandu, hailing from Maharashtra, in the by religion, brought by mother complaining of fever and cough since 8 days.
Remote will work now. You're on top of.
That was apparently asymptomatic 8 days back when patient developed a fever, which was sudden in onset, moderate to high grade, but undocumented, intermittent in nature, not associated with any aggravating or relieving factor, but subsided on medications. No history of rash or chills or asthma, but he has a history of evening rise of temperature. Dry cough was non-spasmodic, associated with post-oral vomiting. Vomiting contains food particles. No history of throat congestion, no history of any coughs, but he has a history of he's playing with one of his friends who has a history of pox contact. Means maybe an active pox disease. No history of night sweating or history of weight loss. No history of periorbital edema of facial puffiness or decreased urine. No history of any breathlessness or fetal edema. No history of blood transfusion. No history of jaundice. Hematemesis of melanoma. No history of previous admission. ANC history, was a registered case. She has undergone 3 to 4 ANC scans. She has taken calcium and with iron supplements. TT injections were received. No history of any pregnancy induced hypertension or diabetes. Birth history, full term normal vaginal delivery. Birth weight was 3 kg. Baby died immediately after birth. No history of NICU stay or neonatal jaundice. Immunized up to 5 years of age. Dietary history, he is adequately taken protein and calorie for his age. Developmentally normal. Family history is no history of similar complaints in family. On examination,
Causes of fever and cough for 8 days.
Alert lung,
What is alert?
lower respiratory tract,
What is lower respiratory?
with the vocal cord.
Pleural effusion, fine. Bronchitis, laryngitis, maybe pneumonia. What else? Can be sinusitis. Can Now tell me the causes of fever with this description.
Pneumonia, enteric fever.
Okay. So you're discounting the cough. You're just saying for this view. That's fine.
How was the
Viral, bacterial,
Bacteria.
Autoimmune, malignancy. What type of fever?
Bacteria.
Why bacteria?
High grade sudden onset.
So sudden onset is usually not bacterial. Bacterial has to localize. So it starts with slightly low fever and then goes.
We should see how the child was in example.
So how was the child between the fever? Happy? Active. Active. So not bacterial. Unlikely. Election second. No, you have to be politically correct. So, these things are useful, but not always conclusive, right? So let's go one by one. Sudden in onset fever, we said it could be viral autoimmune or anything. Moderate to high grade, undocumented. It's very difficult to say what is high grade and what is low grade when it is not documented. What type of which fevers are intermittent? Tuberculosis? Yes. So it's not typically intermittent. Low grade runs for some days and may not be there, and then again it may come. Intermittent fever are not associated with any aggravating factors. So what are the aggravating factors for fever? What he means probably is no other associated or features, like there is no rash which comes with fever, there is no joint pain with fever, or there are no chills, triggers, or sweating. Subsiding on oral medication. Now here it's important to tell how many times oral medications were taken. If the child required 3 doses or 4 doses of antipyretics per day, then you are not dealing with an intermittent. You are just dealing with a continuous fever which is responding to antibiotic. The moment the antibiotic gets over, the fever starts coming up. And evening rise of temperature. I was just checking what is the normal range there. So evening rise is normal or abnormal? Normal. Yes, it's normal.
How many increases by 0.5 degrees Celsius per day?
When is it minimum?
Excellent.
So if there is a documented fever and there is an increase in the fever from what it was in the morning to evening, then you would say evening rise. Or if the fever was coming only in the evening with a temperature which by definition is more than 37.8, then you would say that this is fever or 38.4, 100.5. Most people take now 100.5. You could take 100 as go back. You mentioned somewhere breathlessness. No history of breathlessness and feeling weak. To rule out cardiac causes. I thought breathlessness was also for respiratory causes. Because we are dealing with fever and cough for 8 days, breathlessness would be more relevant for that. Of course, also for cardiac. So, what are the causes which we give breathlessness? Fever, cough, and breathlessness. एकदम simple. No trick question.
Pneumonia. Fluid poisoning.
Interstitial. Yes, sir. Interstitial doesn't cough. That's why miliaries don't have cough. Interstitial disease. No cough. Now, if you are going to talk about hypersensitivity pneumonia and interstitial affection, and then cough. And the cough is because of the hypersensitivity or the allergy, the problem to the local. Okay. Why did you ask for blood transfusion? So, it's no point in putting a long list over here. You should be able to identify what you are dealing. Any weight loss? So when you're talking about coughs or tuberculosis, by definition, you have to have few things that you want to ask. What are you going to ask? On your written no is past history of coughs or history of cough contact. What else? Fever and weight loss and cough. Because the definition of tuberculosis has all these parameters. So when would you suspect tuberculosis? Tell me the features when you suspect fever and what type of cough. Then you start thinking.
2 weeks.
More than 2 weeks, unremitted. Productive, I don't think is part of the definition, but more likely to say that 2 weeks of cough or 2 weeks of fever with more than 5% of weight loss from the last measured in last 3 months, six. Okay. So what is your impression? Impression का slide missing. So why is it important to have that? Not because we do it every day.
To localize the etiology.
Why examine करके etiology ऐड करते हैं ना जल्दी के.
We can know what to focus on.
Exactly. See, the idea of having clinical impression on history is what to look for on your examination. So, what do you want to do? What is called focused clinical examination. So you will automatically focus. Sorry, you do all the full examination, but you will focus on certain things so as to pinpoint your diagnosis. So you expect the abnormal examination and confirm it. Any one of you? Diagnosis? No. On history, clinical impression. No? Then you can get. Okay. अरुष इधर आ जा इधर आ जा कुछ नहीं करेंगे इंजेक्शन करके ही देंगे My feedback in my whenever patients get admitted under me, I always ask who is your favorite among all the residents, and almost invariably it is the one who has they remember them the most. They become friendly. I'm not joking. Somebody quickly before he gets this, let's do a respiratory. असं नको करू असं असं
Has no visible signs of respiratory distress, mostly sort of feeling. Respiratory RRT, breathing mobility. is active intestine surrounding. No muscle is wasting or kind of surrounding. Chest shape and symmetry appears normally.
You want to say symmetric or asymmetric expansion of the chest. Any part of the chest is not moving. So the abdomen seems to be normal. Umbilicus is not stretched. What about his growth?
Muscle mass seems to be adequate and height.
7 years.
7 feet would be
Hello? Yes.
On examination, patient was febrile, pulse 1 minute per minute, rhythm regular, low volume, equal on both sides, no radial female. Respiratory rate was patient was tachypnea 26 per minute, respiratory is 98 on right arm. BP 104 by 72 mm per inch on 50th centimeter. Extremities were warm, either present, no icterus, sinuses, swelling, and nothing. Head to toe examination was normal. Anthropometry,
Chest exam. Respiratory. Okay.
weight is 18.5 kg, which corresponds to -0.0 standard deviation. Length is 78 centimeter, which corresponds to -1 standard deviation. BMI is 14.7, which corresponds to -1 to 0 standard deviation. Impression is normal. Systemic examination, respiratory system on inspection. Bilaterally symmetrical chest, respiratory rate was 26 per minute. Thoracoabdominal type of breathing. Mediastinum was central. No abnormal dilated veins or scars. Cell signs was negative. On palpation, cell signs confirmed which was negative. Apex bit felt at 15 intercourse of space. 1 centimeter lateral to the mid-clavicular line. Decrease the movement on right side intramammary region. Tactile local flammatives increase on right side intra-ankle. No local tenderness was present. On percussion, anteriorly on right side tympanic node are all over the lung parenchyma except the inferior intercostal space. Dullness was present. Could be a liver dullness. Confirmed with tidal percussion. On the left side, tympanic node are all over the lung parenchyma except in fourth intercostal space near parasternal line. Could be a cardiac dullness. On posterior side, it was both suprascapular and interscapular region tympanic node are bilaterally. And in infrascapular region, dull node on the right side and tympanic node on the left side. In axillary region, tympanic node are bilaterally, and infraaxillary region, dull node present on right side and tympanic node on left side. On auscultation, bronchial breathing, air entry was released from the right side. Vocal resonance decreased from the right side. For abdominal examination, on inspection, abdomen distended, superficial veins not visible. Because it's everted. palpation superficially soft and non-tender, but deep palpation. Liver was palpable 8 centimeter below the right subcostal margin, and it was firm in consistency. Left lobe not palpable, spleen was not palpable. On percussion, liver span was 10 centimeter. No ascites. On auscultation, bowel function. Cardiac S1 S2 had no. Yes.
Diagnosis.
Seven-year-old
Tender hepatus pneumonia.
hepatomegaly.
Tender hepatus pneumonia. Spleen was not palpable.
No.
Agree, don't agree.
The hepatomegaly can be due to push down liver.
Yes, check.
It
Check.
may be-
Tidal percussion has been checked.
So what does tidal percussion tell you?
It differentiates between the dryness on the right side is due to liver or due to pleural effusion.
So here what is it?
According to this, seems hepatomegaly.
But it is outside
It
the
is
thorax.
outside. Probably pushed down.
So you're only 2 centimeters. It's only 2 centimeters left. How are you going to get the tidal percussion? I'll simplify the question. You have a child with liver and a pleural effusion. How will that tidal percussion be? How will you do tidal percussion in that? Liver moves,
But
your effusion is going to be there. So you're not going to be able to. It will be very difficult. Tidal percussion is useful when there's a normal chest and liver. You want to make sure that this is not effusion, but this is a liver dullness. When the patient takes a deep breath, the liver moves down and more area becomes tympanic. There is an effusion. The effusion is going to be sitting there. Okay. So it's not going to be easy to differentiate the two. So is it empyema or no empyema? That is the first question. Or let's start even before that. You think there is consolidation or no consolidation? But respiratory rate is 26.
maybe the pleural effusion is causing all these things, not the parent.
That's what we have been taught, that if there is only an effusion but no consolidation, then tachypnea will happen only if there is significant size of pleural effusion causing compression. But then I will argue saying pleural effusion should not give you cough at all. Why should pleural effusion give? So it started with with a cough, a fever, then developed cough. That would be your typical consolidation. Then comes breathlessness. Then that means complication of consolidation, which could be a mnemonic effusion or it could be an empyema. But if the fever came, then the breathlessness came, and cough came later or did not come as much, and sudden onset breathlessness, then you are thinking more in terms of tuberculous pleural effusion because it's an allergic reaction. So fever, bones focus, breaks, gives rise to an allergic reaction, sudden onset pleural effusion that causes the breathlessness. because it's large and sudden. Okay, so this way it doesn't fit into the allergic pleural effusion category. Now, whether this is empyema with effusion, empyema with consolidation, or only pleural effusion with because of TB, we would not know. Child is too comfortable to be having consolidation with empyema. Okay, that's the first. Second thing, the amount of dullness that you see is another. Tell me one more condition where you will say, not one, but more condition where you will see hepatomegaly with pleural effusion. Think broad. Don't forget the fever cough. Liver abscess, right-sided liver abscess. What else? I'm not asking necessarily tender hepatomegaly, but you could classify cardiac. Cardiac cause, very good. What else? What cardiac cause?
Congestive cardiac.
Congestive cardiac. Okay. बारिश गया तो भूल जाते हैं. So then you have hepatomegaly and pleural effusion may not be at the same time. Could it be constrictive pericarditis? In constrictive pericarditis also you can have pleural effusion and you can have a very large liver. Bilateral more common, but we have not done the X-ray. Could be more on one side, less on.
Keep that could have been a
Chest pain, not necessary. It's a slow process. Tuberculous constrictive. You will have distress, you have breathlessness, important. And of course, loss of appetite, chronicity. JVP. So JP should be checked. Any child with liver and respiratory problems get press on JVPs. How will you invest? You have the X-ray. Assuming this image is distorted, right? Or is it because the child doesn't look like this? Is a photography issue. That's
it's a chest X-ray, PA view, well centralized, well exposed. So trachea in a central position.
mid-inspiratory, inspiratory or expiratory. Does it matter? How does it matter?
When in expiratory, for
What is the
instance,
ideal position for it? Mid-inspiratory. Very good. What happens in expiratory?
in expiratory, the lower portions are distended with blood, so that may appear as infiltrates.
Okay. Okay. So you can have heart size may look bigger because the diaphragms are up. There could be excessive congestion could be seen. Underexposed, what is the problem? Overexposed, what is the problem?
Overexposure, the normal hymen may seem to be, may look like infiltrate.
Basically, overexposed means you will see posterior structures more defined than the anterior structures. The spine will be more visible, but heart being in the anterior mediastinum and areas like middle zone will be in anterior, you may miss a consolidation or at least increased pulmonary vascular. Similarly, in the soft plate or what is called as underexposed plate, you will see the front areas more evident and you may miss lesions on the posterior end. So this is definitely an overexposed, vein in expirated plate. But if you see there's a small middle fissure which looks like a middle fissure, which I can see here, going like this and not remaining straight on the right side. And the right diaphragm is higher than the left diaphragm. That is normal. Always confusing. And remember. Heart pushes. Heart sits on the diaphragm is what you remember. So the left diaphragm is going to be lower than the right diaphragm. You think that's a consolidation there, the right lower zone? And if the middle fissure, instead of being flat, if it's going downwards, then there could be a consolidation with collapse. If the upper lobe collapse is there, then the middle fissure can go up. At least I can't appreciate on this X-ray much of an diffusion. But right-sided. So another important thing is if you see in a well centralized X-ray, if you see the right heart border well beyond the right side, think of a problem. Okay, whether it is respiratory problem or a cardiac problem or a position problem, that is abnormal. Always take it serious. So something. Any other
So the air on the right side. This air, the overexposed part seems to be consolidation, whereas this part seems to be.
No, so you have to remember that the X-ray is a 3D image. So that doesn't mean that there is air under the diaphragm or anything, right? This just means consolidation. Consolidation means we assume that consolidation involves the whole of the lobe. It's not necessary. It could be in lobules. So you will have some area of the lobe may still be open. That's fine. So if you ask me, then this would be the area of consolidation. And whenever you see the middle fissure, which is prominent, it means there is a respiratory infection. Now, whether there is empyema, there is pleural effusion or just consolidation remains to be seen. But if it is clearly seen middle fissure, that's a sign of infection. What I was worried more about was this area, assuming that this is the heart and it is going further beyond the right side, retrospinal area coming out over here. And I can't see much of effusion here, at least on this extent. Neither can I see. I can see this angle, which is pretty clear, and this angle also, which is fairly clear. So I am not very much sold on empyema or effusion on this extent. How will you know? What will you do further to know whether there is effusion or empyema or ultrasound? So one could actually say you could have done ultrasound instead of X-ray, but at least after the X-ray, because of the cost and competency, etc. But CT scan definitely. Okay. Go ahead. Next. Are there other investigations? Normal. Normal, abnormal. There are a few bold ones. Chronic liver disease. This is chronic liver disease. You have done LFT, you have a large liver, and your albumin is low. You're unnecessarily looking at fever and so this is borderline report. I agree. The AG ratio is not reversed. AG ratio is also reversed with the low protein. I would be more concerned. The AG ratio is maintained, and there is albumin which is on the lower side, and total protein also slightly on the lower side. I could leave it as nutritional or something rather than worrying about. But I would definitely think about if you do only one test in liver function, please do go from it. That is the most actionable test in most countries. No CBC. What is OLD?
Malaria, dengue, lepto, and dengue. Malaria, dengue, and lepto.
What is O?
Optimal test for malaria.
Optic. Interpret CBC. Somebody should standardize how a CBC should be written. Every single lab writes it in all different ways. As a hematologist, then say lymphocytes have to be written first. Neutrophils are of no value. Pediatrician always look for where is the neutrophil. Come on, fast. Chalo. Interpret this report. Start with hemoglobin. 9.
Low
Low. What next you want to see?
indices.
Which one?
MCV.
MCV. 64.5. Low. Low, very low, borderline low. Appropriately low or very inappropriately. And I mean, what I mean by that? The hemoglobin of 9, 64 is, if it was 54, 52, I would say inappropriately. What else? What next you see? You want to see? Sorry?
Total count. WBC count.
No. Let's see. Hemoglobin to khatam karo.
MC, RDW.
Very good. So what is RDW? Normal, increase, normal or low? There's no increased RDW, no, but only normal. Sorry, there's no low RDW. Normal or increase. Someday we'll sit and discuss RDW, SD, and CV kind of. So what is this? Normal RDW. So what is your diagnosis? Or for the hemoglobin?
Microcytic. Hypochrome.
Infection can also lead to.
No, so thalassemia minor or not minor? That's my question. Or iron deficiency anemia or anemia of chronic infection? Don't go by the history, just go by the sequence.
Normal would suggest filtrate.
Correct.
Whereas iron deficiency anemia would suggest
RDW would be increased, right? At least it should be that. Okay. What about WBC? The other thing you should see is the RBC, right? The RBC. The hemoglobin has gone down to 9.9. Sorry, gone down to 9. The RBC also proportionately should have gone down, which happens in iron deficiency.
Do you have any? Sorry, sir.
No, go ahead.
Do you-
Menzel's index.
Yeah, please. When you see normal RDW with anemia, immediately calculate the Menzel's index.
Calculate.
What is Menzel's index?
64.5 by 5. 13.
Approximate. 13 fives are 65.
So more than 13.
Huh.
Because 5. It's less than 5. So then it's slightly more than 13. So not valid, not such a thing.
13.
I don't normally calculate Mendel. That's why I didn't ask about Mendel. Good to know. Important thing to see here is hemoglobin has gone down to 9. The RBC has gone down to not gone down that much. Means what? Means you have RBCs but not enough hemoglobin. That means it's more likely to be not iron deficiency. Because an iron deficiency, the number of RBCs will also go down. That's the basic principle of Menzel's. I'm just explaining it to you in grammatical form. Mathematical form, that is where your Menzel's will come in. Yeah, go ahead. What else? 6.9 WBC. So what? Straight tuberculosis. No, bacteria cannot give 6 points unless the child is in bone marrow shutdown.
Neutrophil is on the higher side. The difference.
But your total count is only 69. What is the ANC? No, 7 pakad ke chalo. 7,000 ka 64 is 2/3. That's hardly anything. 2,330. Nothing.
Some infections may suppress the marrow.
That's what I'm saying. Na bone marrow suppression. I agree with you. We're not talking about bone marrow suppression. We are not. Chronic infections may not give. So this doesn't look like an acute bacterial infection. That much at least you can say. Unless you say this is a acute bacterial infection under control, which are cured. Now that parameter is not visible. Do you think this is likely to be an EBV? Viral infection, fever, 7 days, cough, liver which is large. Not this.
Lobar pneumonia does not
That's
go.
not. On CBC. Lymphocytes should be more atypical lymphocytes or monocytes at least. Many labs they can't make out atypical lymphocytes. What are like? Again, politely, many machines don't recognize atypical lymphocytes. They put it as large number of monocytes. Fair enough. What did you do for it? Tap? Sonography? Right sided pleural. Big, large, big or small? Tappable, non-tappable? Non-tappable. Correct. So that is what clinically looks like. X-ray doesn't show. Sonography shows it. So you're going to tap it now. The non-tappable means you may not need to tap, but tappable under ultrasound guidance. Would you do a tap? GL yield is better. So GL yield is better for gene expert. Who want to see ADA levels in
ED levels are not standardized for.
Yeah, I'm agree. No, so would you tap this child or would you not tap it? What antibiotics again? What medication? IV? Piptas. Anticox not. Investigation. Mantu done. Mantu done negative. Parents X-ray? Not now. We'll be doing. Thank
The X-ray did not seem to be pleural acute.
Correct. So that's what I said. X-ray may not show you pleural because if it is small amount, sliver of fluid, you will not see on the X-ray. First of all, as I said, the X-ray was probably not maybe moving or we have not seen an appropriate one. But it's very well known that X-ray will not show you an effusion which an ultrasound will pick up. That is the reason for doing it. Also, the reason for doing ultrasound is if you see a clear fluid or whether you see fluid with particulate matter, then early empyema can be picked up and detected, differentiated on this. And accordingly, you can change your end. And if you see a particulated matter or if you see early empyema, you would tap and send it for culture and confirm that this is empyema. Then you can give antibiotics for that much time. Thank you. Any questions? Thank you very much.